Thank you, Mary, for that introduction. So I was just, as Mary said, I was just recently invited to the board of directors, and Monday night was our first meeting. And I came home and told my whole family about, how amazing that experience was to join such an elite, really an elite group of people who are trying to fight blindness in Canada. And I was so, overwhelmed with emotion and excitement about what we can do together. So all of you play an important part of that, and it's been great working with Mary over the last few years, and I'm excited to continue working with her. So I was asked today to discuss age-related vision loss. What Mary told me was that some of the vision quests in the past were really exciting during the question and answer period. So I thought, why don't we just start with a question and answer period and cut right to the chase? So we're going to do top 10 questions asked by my patients. I have been working at North Toronto Eye Care since 2010 and Toronto Retina Institute for the last few years, but I just recently moved, so I have started working in Windsor, Ontario. And so that's what's new with me. My specialty is still medical and surgical retina, so I'll be practicing that in Windsor and in Detroit. Question number 1, what is the macula? Well, the macula is basically the center 5mm part of the retina. It determines your color and your detailed vision. And the visual acuity is based on the integrity of the macula. And this, whether you have a disease or damaged macula, that cannot be compensated with glasses or lenses. In terms of where the macula is in the retina, it sits in the arcade to arcade. So here's my little laser pointer. What we call the arcades are the large veins and arteries that come off of the optic nerve. I guess the first question I should ask is, how many people in this room are not able to see the screen? Okay, about a quarter. Okay, so I hope that my description is adequate, and please interrupt me if it's not. So the optic nerve is basically in the center of the retina, in the back of the eye. The fovea is the center of the macula, and the macula is the temporal area. Temporal, when I say temporal, I mean lateral, or to the outside from the nerve. So the retina is actually a lot larger than a lot of the photos that we're used to seeing. This is a wide field image, so you can tell that the macula is that center square of the retina. So when we look inside the eye, sometimes we have to put a little pressure on your eyelids, have you look all the way around. The reason for that is because we want to see all the edges of the retina. The best way to see if someone has flashes of light or floaters is to do something called scleral depression, which means that you're indenting all the outer layers of the retina, which allows us to look for holes and tears and detachments and things like that. Today we'll be focusing our discussion on the macula and the center of the macula. So what I find fascinating, part of the reason why I went into retina, is because the correlation between the anatomy and what we get to see in the eye is really amazing. When we look inside the eye, we get to see blood vessels and white blood cells and fat deposits and fluid, all of these things that we can see with the naked eye. There's no other part of the body that you can look inside without cutting it open and being able to get all of these clues about what's going on in your body. So here we have a specimen, a cadaver specimen, and you can see how the retina is so thin. This is the eyeball, the front of the eye, the cornea, lens, and the back of the eye. And the retina is so thin. And the choroid is the layer that sits right underneath the retina and is the most vascular layer per square inch. Vascular meaning the most amount of blood vessels per square inch in the entire body. That shows how much blood supply and how important the retina is within the body. So basically, I'm sure many of you know this since you're Vision Quest experts. The light enters the cornea, enters the lens, and has to get through the vitreous in order to get to the macula, and then the retina processes the light that you see. If many of you are current patients in a retina office, this is probably the most common picture that you see. I train all of my patients to basically read their own OCTs. This is called Optical Coherence Tomography, or OCT. And this shows all the 10 layers of the retina. And it can give us details up to 2 microns in terms of detail. And that is truly astonishing. If you cut a retina and look at it under a microscope, it looks very similar to this. And this is what we're able to get with a camera that takes about 1 second to take this photo. And it is non-invasive, there's no radiation. So we do about, 100 OCTs a day. Question number 2, will I go blind? So this is a very difficult question for us to get as physicians. It's usually the most commonly asked question at the beginning of a visit, because patients have a lot of anxiety before coming to us. They have a new diagnosis. Their ophthalmologist or optometrist who first saw them, gives them a general idea, maybe a hint of what's going on, but not the full story. So there's a lot of anxiety that builds up between the time that you see your optometrist or ophthalmologist until the time that you see a retina specialist. So obviously the answer is it depends on your diagnosis. And not only that, it depends on about 100 other factors that go into your disease, whether it's chronic, whether there are genetic factors involved, environmental factors. There's a lot of things that determine whether you're going to lose vision or not. So the technology that we have to purchase in our office, the technology that we have in our office, is really helpful when it comes to establishing diagnosis, establishing management, and these may include, OCT angiography, fluorescein angiography, autofluorescent, wide field imaging, electroretinography. Whenever the patients come back and I say, okay, we need to take an additional test, they don't understand necessarily why, because they feel that they just took, additional testing. But it is really helpful for us as clinicians to get the most amount of information possible when trying to figure out what to do with your specific eye. So nowadays, in terms of treatment, well, there are really life-changing treatments. Life-changing literally because many years ago, there were no treatments for some of these diseases. So we have these amazing drugs like Lucentis and Eylea and Ozurdex, and all of these drugs help us to treat disease in the retina. And the Ontario government is extremely generous in their support of these drugs. So a lot of these drugs are covered by the Ontario Drug Benefit Plan, and if you don't have the Ontario Drug Benefit Plan, you can get something called Trillium, which pays for your, it's like a health plan that pays for your drugs. Obviously, you have to pay into it, but so practicing in Ontario all these times, all these years, and hearing the stories of our other retina colleagues in BC and Alberta and the East Coast, we're very, very lucky that we don't have to worry about coverage in Ontario. It's really great coverage. And these are very expensive drugs. So I consider myself lucky to be practicing in this province. So a question I oftentimes get is, why is it that my friend got 3 injections and I need a million injections in my eye. Why, or my friend, or my brother, or my other eye went blind from this injection, and you're giving it to me in my only good eye. Why are you doing that to me? It's a very understandable question to get when you are so worried about losing the vision in your only eye. And the reason for that, the reason why we do that is because every eye is different. Every patient is different. And just because something happened to your other eye or to someone that you know, it doesn't mean it's going to happen to you, even within your own body. So, if I do lose vision, can I get an eye transplant or a bionic eye? Well, I wish it were that easy. There are three kinds of transplants that we do in the eye. Cornea transplant, which is very, very common, and the Argus 2 transplant, which I'm sure you've heard about at prior vision quests, where they implant a chip in your retina that is specifically for retinitis pigmentosa, and that is specifically for people who have only light perception with retinitis pigmentosa. So most of the time, to decide to know whether you're a candidate or not, your vision is usually too good to be eligible for this transplant. And in general, for a lot of the clinical trials that are out there, your vision has to be pretty bad to be entered into a clinical trial. So cornea transplants, Argus 2 implants, and we can do retina translocations, which means you cut out a piece of retina outside of the macula and you slide it into the retina. And we can do that in the operating room, but it is highly controversial and not controversial, but more experimental. And you typically only reserve that kind of surgery for if you are quite desperate. So, if you do decide to do retina surgery, do you have to take my eyeball out in order to do the surgery? No, you do not. When you say surgery on the eye, do you mean laser? No, actually, we have to cut the eye. Even with cataracts, even with pediatric surgery, you do have to cut the eye. The incisions are small, and they don't leave a lot of scarring, and we may incorporate laser into the surgery, but it is actually incisions into the eye. So a little bit about retina surgery. Yes? So I'm just going to repeat your question in the mic. So the question was, can you have surgery for macular degeneration? The short answer is no, outside of a clinical trial. Sometimes you have to operate on patients with macular degeneration for other reasons, like a retinal detachment would be the most common cause. And there, in this diagram actually, you can see how we do the retina surgery. It's called a vitrectomy. And you make 3 ports. One has an infusion line for saline. The other one has what we call a cutter or a vitrector, and that's what cuts the vitreous and removes it. And the third port has a light. So your feet are operating the pedals for the microscope and the vitrectomy machine. And your hands, one hand is holding the light and one hand is holding the cutter. And you cut out all of the vitreous. And for example, if you had a retinal detachment, you would suction the fluid from behind the retina that caused the detachment, and then you would laser around the hole to put the retina back on the wall of the eye, on the sclera. But you can't do anything about the macular degeneration. You basically just looked at it, and that's about it. There's nothing you can do during surgery. Historically, though, a lot of patients who have had vitrectomy, their macular degeneration slows down. And we don't know exactly why that is. It could be because there's more oxygen getting into the retina after vitrectomy surgery. There's less traction on the retina because you've cut out all the vitreous. So that's a very good question. A common question that I get is, if you take all my vitreous out, what replaces it? And it's just basically the saline solution that we use during the case. It gets replaced by your body replaces it on its own, so it gets recirculated. So we've discussed a lot already, but I haven't even examined the patient yet. These are some of the questions that we get even before I get to know what's going on with the patient. So let's start with the most commonly diagnosed disease in an age-related patient, so macular degeneration. What is macular degeneration? Well, when I look into a patient's retina, if I see blood or fluid in the retina, it could be scarred. There could be something called drusen, which are deposits of protein. That is wet macular degeneration. When we do that OCT picture, you can see here a cross-section of the retina, and there is blood and there is fluid, these cystic spaces within the retina tissue. And remember, this is less than half of a millimeter. So this thickness that we get to see on these pictures represents less than half of a millimeter. So what do we do about macular degeneration? Well, again, as I mentioned, we have excellent treatments that are about 90% effective. They are 90% successful at improving or stabilizing your vision, which is amazing compared to prior to 2000. Prior to 2006, we had a couple of other treatments, but there was nothing prior to the year 2000. So these drugs, Eylea and Lucentis, really revolutionized the field of retina, and it made retina doctors a lot happier, actually. And you hear, when we talk about the history of retina at meetings, conferences year after year, people talk about how they would just, sort of hug the patient and just sort of try to support them through their blindness, and now it's completely different. So let's talk about future treatments. You all may know that there's a heavy burden on the patient and the patient's family to bring them into the office every month for their injections. That is a difficult burden for the family to endure. There are a lot of people who take days off of work, many days in a year, to bring their family in, or people have to fly to bring their mother or father in, or the spouse comes in and you spend the day at the office, and it is a huge burden, and we all know that, and we all feel really bad. And lots of research dollars have been put in to figure out how to reduce this burden, how to create drugs that last longer. So there is a longer-acting drug on the horizon. It should be available by the end of next year or the year after. There are also slow-release depot drugs where you can put a little reservoir injected drug and let it slow release. So there is hope. And when patients ask me that same question, I answer, this is the best treatment that we have right now. We didn't have this before. So fast forward a few years, there'll be another better, best treatment that you'll be getting. So think about this investment as an investment of your time into your future of your vision. So does the injection suck out the blood and the fluid? No. If we put the needle that we put in the eye, if it touched the retina, that would be bad. That would cause scarring or a retinal detachment. So you can see from this picture, the needle enters the eye. We keep it in the middle of the vitreous cavity, and it releases the drug. The drug then dissolves into the retina tissue and helps close the blood vessels and stops the blood vessels from leaking blood and fluid. How many injections will I need? Another version of this, will I need injections for life? Well, we don't know the answer to that for each patient at the beginning. It would be great to be able to predict how many injections a patient needs. And there's been many studies that have looked at this question, but we don't have a conclusive answer. So generally, we start with 3 monthly injections, and then we see. It all depends on how your retina does. It all depends on how your retina responds to the medication. And we want to give your retina the best treatment possible with the least amount of risk. So we're not going to over-inject you unless we thought it was the best thing for your eye. And oftentimes patients feel that, my vision is not improving, why are you still giving me injections? Well, if you have a healthy retina, even during the maintenance phase where your vision does not improve, it has been shown that even when your retina is healthy, more injections still help you maintain your vision down the road. And that's what we want. We want to invest in your vision 20 years from now. We don't want to just think about tomorrow. So, which is the better kind of macular degeneration to have, the dry kind or the wet kind? Well, it used to be that the wet kind was the bad kind and the dry kind was the good kind. But in all reality, most people who have the wet macular degeneration also have dry. And people don't realize that because no one really talks about that. When you come into the office, you're diagnosed with wet macular degeneration, you think that, oh, if you had dry before, now you're wet. But no, the dry continues. So even with successful injections for the wet kind, your wet may be completely inactive, but your dry may still progress because there is no active treatment at the moment commercially available for the dry kind of macular degeneration. So if you look at these pictures, there's two types of dry macular degeneration. There's the type that has the drusen, and what drusen means is they're age-related protein deposits. And you can see in the outer retina all these bumps. Someone can have complete 20/20 vision with all of these bumps. It's just protein deposits, but we watch patients that look like this to make sure they don't develop the wet kind. Here is called geographic atrophy. Atrophy means the tissue doesn't work. So there's part in this area, you see this big black spot in your macula. You don't have to have retina training to understand that this black spot means that you cannot see through that. There is no tissue, viable tissue in that area of the macula, which means that you're not going to be able to see. So there's different types of dry macular degeneration, and only when the doctor looks in and does some of this testing, this is called autofluorescence, this is called the OCT, and this is a color picture, fundus picture, that's when we can really understand what part of the macula is affected and whether it included your fovea. The fovea is the center part of the macula, whether it included the fovea in the atrophic part. And you can see over years, the area of the geographic atrophy can get bigger. Not everybody, depends on the types, which is again controversial and not completely established, but there are certain types that can grow and expand over years. So future treatments of dry macular degeneration is really a focus of a lot of research funding. But there's nothing yet commercially available. So in terms of clinical trials, there's the brimonidine injection that is actually coming to clinical trials in Canada by Allergan. There is some cell-based therapy, that's cells from the umbilicus, that gets injected into the eye. That's a little bit different from gene therapy. There's also gene therapy, complement factor therapy. So here are some images of that. Here you have that brimonidine DDS injector that gets injected similarly to some of the other drugs that you can inject. This is, again, for dry macular degeneration that's in clinical trials. This is a study called Prema. This is a device called Prema. It has been studied in France and is now being studied in the United States. And I've been to a couple of lectures on this because I was previously living in Pittsburgh and they're doing a clinical trial in Pittsburgh for this. And this is an implant, and you can see the size of this implant right here, very small implant that connects to a camera much like the Argus 2. And this is for geographic atrophy, dry macular degeneration. So the Argus 2 was only for retinitis pigmentosa. So this is going to be amazing if it becomes successful for patients with dry macular degeneration. when we talk about gene therapy and future treatments, this is the way the genes get delivered. So I explained a little bit about how vitrectomy surgery is done, where we go inside the side of the eye. And here is a little cannula where you inject the cells underneath the retina. So you basically create a retinal detachment and you inject the medication into the cells. You can go from the inside of the eye with a cannula like this, or you can go from the outside of the eye, behind the eye, and inject the medication underneath your macula. So the surgery in this is really amazing, interesting surgery. So that's future treatment. So what about current treatments? Well, the AMS are grid weekly. I tell all of my patients that. AREDS formula vitamins, those are the ways to treat dry macular degeneration currently. Unfortunately, in Canada, we don't have something called a 4C home monitor. This is a little camera that does an AMSR grid basically for you at home. It connects to your doctor's office, and if you don't pass one of the tests, a message gets sent to your retina specialist office to tell them that maybe you have some new distortion in your vision and they should come see you right away. So I'm hoping that this will come to Canada soon. Which vitamins should I take? Another very commonly asked question. Well, which vitamins to take is controversial. There are many kinds of vitamins. There was AREDS 1, which established the type of vitamins to take, and there was AREDS 2, which sort of restudied it. So what do we know? We know that antioxidants are essential. You need to have antioxidants like lutein and zeaxanthin. Those are the types of vitamins that you have to take. Omega-3s, they studied that, and it wasn't completely conclusive that it helps macular degeneration, but omega-3s are great for dry eye. Not dry macular degeneration, dry eye. So people who have tearing, burning, feeling like something is in the eye, that's usually from dry eyes. So taking omega-3s is good for that. Again, the dose of zinc is also controversial. They studied that a lower dose of zinc is equally as effective as a higher dose of zinc, and any additives to your diet, vitamin E, zinc, any high dose can have some negative effects, not in everybody, and it's rare, but that can happen. So again, a lot of this is controversial. And you'll see when you go to the store, there's an endless amount of choice when it comes to vitamins, and it can be very confusing. Another question, should I have genetic testing done? Well, this is also controversial. Everyone, regardless of whether you know you're going to get macular degeneration, you should be eating green leafy vegetables, and you should be eating orange vegetables, and you should be eating a lot of fish and getting exercise. These are things that everybody should be doing. Whether getting a genetic test will motivate you more or not, that's a personal decision. And if it would motivate you, then absolutely, ask your eye specialist about getting genetic testing done. In Canada, the commercially available test is Macula Risk, and that, to my knowledge, that's the only commercially available one that can be done outside of a lab. And specifically about genetic testing, there have been retrospective studies. Retrospective means looking at past data that shows that depending on the genotype, depending on your genes, that certain vitamins could be bad for you. Like the zinc that could make your macular degeneration progress more. You would test that with VitaRisk. But the issue is we need a really big, long-term prospective study, meaning looking at patients in the future, where half the group would get zinc with a certain type of that genotype and half of the group wouldn't, and then you study that. But that is really, really expensive, many, many millions of dollars, and the funding has to come from somewhere to study that. So other causes of age-related vision loss, diabetic retinopathy. A lot of times patients will say, I have diabetes, I see fine, why are you sticking a needle in my eyeball, or why are you trying to laser me? Well, you can see fine. A patient like this, where you can see this is all fat, and in the OCT, this is all fluid, and the eye may be filled with blood, patients like this can still see 20/20. So there's a difference between patients with macular degeneration. They oftentimes have vision loss, and they come and they say, I can't see out of my eye. Patients with diabetes typically can see fine, maybe because their retinas are younger, maybe because it has been a slow growing event and they're just used to it, but they can see fine. But as you can see from these photos, that the retina is not fine. And it's very hard to get a patient to understand why you're treating them without images like this. And I try as hard as I can to show my patients their images, their photos, their OCTs, so that they can understand, because otherwise, why would they trust that I am injecting them or lasering them for the right reasons? The second reason to treat someone with diabetes is called proliferative diabetic retinopathy. So the picture before that I was showing you, that's called diabetic macular edema, where you have fluid in the retina. And here, this is called proliferative diabetic retinopathy. So those are the two reasons why we would treat someone with diabetes. In this case, the circulation in the retina is so depleted that abnormal blood vessels try to grow onto the retina. And you can see these abnormal blood vessels sometimes within the retina or sometimes on the optic nerve. Those blood vessels are struggling and trying to remodel the eye, trying to get oxygen, but they basically steal all the oxygen away from the good parts of the retina. And you can grow scar tissue, so this patient has a little bit of a detachment because the scar tissue grew on these abnormal blood vessels, pull the retina off. Those abnormal blood vessels are fragile and they break, so all of this is blocked, the vision is blocked from blood. And again, the center of the vision may see 20/30, 20/40, 20/50, but as you can see, there's a lot of pathology that goes on around it. So, in general, controlling the diabetes, controlling your high blood pressure, controlling your cholesterol, quitting smoking, exercising, and losing weight, this is how to manage your diabetes in your retina. Sounds easy, right? So, what else can lead to vision loss? Glaucoma. So what is glaucoma? Glaucoma is basically optic nerve damage, and this can be caused by high eye pressure, which is most common, but it can also be caused by normal pressure. This is different from high blood pressure. The eye pressure, the intraocular pressure is different from high blood pressure. So you may need multiple tests. Most of the time patients ask, what, do I have glaucoma or not? I can't answer it in one visit. You need to have multiple testing done, whether it's a visual field test or an OCT of the nerve, or pressures taken on multiple visits. So it's not something that can be answered unless it's pretty progressed. It's not something that can be answered in one visit. But I am not a glaucoma specialist, so I'm not going to talk more about that. So, to summarize, we talked about age-related vision loss, wet AMD, dry AMD, diabetic retinopathy, many treatments under investigation. I'm excited to be part of some of these emerging treatments in my own office with clinical trials. I think if you pair that with education, I think that's the best way to offer excellent treatment to your patients. And obviously you guys are going to be, because you are proactive about your healthcare, you're going to be the first to know whether there's something commercially available or if there's something experimentally available in your office. And I always tell patients that we are a small group in Canada. There's only 120 retina specialists in Canada, and you'll see us at conference after conference. There's 76 retina conferences a year. So there's a lot of opportunity to learn and to improve your knowledge and to know what's on the horizon and to know what's emerging that we can bring to you as patients. And you participating in your healthcare like this and being active and trying to learn is the best way that you're going to be the first to get something. So thank you very much. So please ask me any questions you'd like. It doesn't even have to be about what we talked about. You can ask me anything.
Testing, testing.
I'm
Are
running
these
over
mics on?
here.
Hi, I have dry AMD and glaucoma, and I have found in the last few months, many months, that I have a problem seeing in dim light. What is causing that? The glaucoma, the dry AMD, or I'm 85, could it be age? Well, I don't know.
So oftentimes patients with any vision loss notice it more in the dark. And the reason for that is because even being nearsighted, if you're a little bit nearsighted, meaning you need glasses to see far, you may not need glasses to see far during the day, but at night when you're driving, you do. And the reason for that is because at night in the dark, your pupils are more open. They dilate in the dark naturally to allow more light in. The problem with the light coming from the side, that's called ambient light. The problem with the light coming in from the side is that it doesn't focus the same way that the light coming straight at you through a small pupil, through a small hole. So it requires a little bit more vision in order to process the light coming from the side than the front. So when you go to the doctor's office and they put that little pinhole in front of your eye, that pinhole reduces the side light and lets you see right through the center, so the pinhole mimics glasses, or whether you didn't have a cataract or something like that. So for your specific eye, I wouldn't be able to tell you unless I examined you to look for something like a cataract. But the general concept is that with vision loss, night vision is more challenging.
Is there any evidence that restricting light is beneficial to reducing AMD? For instance, comparing people who work underground in low light like miners, do they get less? Are there any clinical trials simply using sunglasses? I suspect not too much money involved, but thank you.
Right. As you know, as you indicated, clinical trials are usually selected based on not selected, but are funded based on if someone has a financial investment in them. That is changing. There is something called the Diabetic Retinopathy Clinical Research Network that was started in the United States, and it involves a few Canadian sites. So even though the name has the word diabetic retinopathy, they have expanded to macular degeneration and other retina-related vision impairments. So that has about 450 sites across North America, and that is not funded by one research company. So that is funded by all the research companies, and hopefully studies will come from there that can answer questions like that. But there is not a study looking at sunglasses impairing the light. But whenever someone is fair skinned, has blue irides or light hair, they are at higher risk because they don't have the pigment, the darker pigment that protects them. And there's pigment in the retina the same way there's pigment on your skin, and that's why fair skinned people get sunburns and darker skinned people get less sunburn. We always advise patients who are fair-skinned to wear a wide brim hat or sunglasses to add further protection.
Hi. What is your knowledge on a laser therapy called 2RT, which is out of Australia?
2RT, are you talking about for vitreous floaters?
No, to help with the drusen for dry MD?
Yes. So there is a site in Toronto, actually, that does that. So I have had a couple of questions on that. I honestly don't know. I read the cursory information about the therapy to the drusen, and what the study showed is that the drusen move away, which is wonderful. But if you look at pictures, the natural progression of drusen without any intervention is that drusen also move naturally without any therapy, and they can change shape and they can dissolve and they can get better. And oftentimes patients with wet macular degeneration, you don't see their drusen. So it's kind of a mystery anyways what happens to this drusen naturally. And so with that intervention, though it did show the movement of drusen, you'd have to have a really big trial to show that the natural progression, the dissolving of the drusen is better with the laser. But it is very, I find it very interesting. I find it very interesting that this option. Yeah.
Yes, Dr. Deepa, thank you for a very informative presentation.
You're welcome.
As was mentioned earlier, there is great anticipation and excitement for stem cells treatment in the offing as yet. In Canada, it may be in clinical trials, but south of the border, you just have to look in YouTube. There are tons of come-ons from the various specialists there. But I'm wondering, what, if any, would be the timeline for Canada with the approval of Health Canada vis-a-vis going to USA to get some treatment done for, the RP irregularity or rods and cones regeneration, things like that?
That's a very good question. There is established sorry? Yes, the question was, what is the length of time it will take for stem cell therapy to be approved in Canada, seeing as though it appears rampant in the United States? So there is an issue with it being apparently rampant in the United States. There have been many centers that have done stem cell therapy, the most recent one in Florida, and many of their patients went blind. And it gave stem cell therapy or gene therapy a really bad name. And so people have to be very careful about seeing an advertisement for a special therapy, because sometimes things can be too good to be true, okay? And so that's what happened at that center in Florida. And the Bascom-Palmer Institute, that's the sort of known as the most renowned eye institute, one of the most renowned eye institutes in the United States. Bascom-Palmer had to do a lot of explaining to the patients in that community who went to that center. It's not a Bascom-Palmer center, but they went to that center to get treatment because these are desperate patients. So I would caution against seeking out a center like that that is not approved. So there are a lot of invasive, experimental therapies that are in clinical trials for example, choroideremia, a lot of these inherited diseases, because usually it's one gene that's missing and you can replace it. So in Canada, these are rare diseases, and that's a focus for a different vision quest. But in the more common diseases like dry macular degeneration, there is no approved therapy right now. And any clinical trials obviously, if you were to go to the United States, you'd have to live in that city unless you were going to fly in every single time they needed to visit. So there is nothing approved in the United States officially. And therefore, I can't tell you when it would be approved in Canada because I don't know when the FDA would approve it. But clinical trials, as you know, they take decades. Something that's that precise and where you have to be that careful, it does take decades to get approved.
We have one last question here. Hi there, just want to thank you for your presentation, first of all. And second of all, just wanted to ask a question about lighting to you. Do you have any concerns or information you could share at all about LED lighting. There seems to be a lot in the media right now about the concerns and retinal changes to do with that.
Yeah, that is a good question, and I don't know the answer to your question. I'm sorry, because again, there's no clinical trial that I can speak to. I have read that you are concerned. I'm concerned in my own house with the different types of lighting, and I don't know whether we should be changing our lights, our energy efficient lighting to something else because it's bad for our eyes. I don't know the answer to that. It could. I mean, I'm on my cell phone 24 hours a day, so I am equally concerned. But there have not been warnings yet to stop using your cell phone or the light from the computer or the TV at this time. The question was, I heard Japan is very advanced and they were doing implants. Japan is very advanced for retina surgery. When we, at conferences, the types of surgical kind of creativity that a lot of the Japanese surgeons use is really amazing. And some of the retina transplant ideas of the experimental ones that I mentioned earlier, a lot of the, not a lot, but a few of the originators of this surgery were from Japan. One of the leading surgeons unfortunately passed away recently, but yes, they are pretty advanced. But they're not doing anything in terms of treatments or implants that are different than what we're doing here at this time.